I want to thank Dr. Jacobson for inviting me to participate in this symposium. It's intimidating to speak to a room of oncologists and think that I have something new to tell you about doctoring. My thoughts today are not comprehensive. I'm sure there are many of you in this room who've been treated for cancer yourselves that could give this presentation with completely different material. Each cancer story is unique, like the individual. I'm simply sharing thoughts based on my own personal experience of being a clinician and a cancer patient. I was diagnosed at the age of 41, married with 3 children. It's worthwhile for you to know that my areas of expertise are breast cancer and lymphoma. And yes, I can assure you that there is a relationship between areas of disease site expertise and malignancy developed. For any resident in the room who's interested in a project with a guaranteed p-value of less than 0.05, I invite you to follow up on this. Cancer is a great lesson in you are not in control. I had the benefit of being able to handpick my medical oncologist and surgical oncologist after 10 years of working with a group of colleagues in a comprehensive cancer center. I turned over my need to control to them as I had trust in their medical care, experience, and communication skills, and I liked them as people. Your patients don't have that advantage. They get the doctor with the open consult slot, or you're the doctor that their doctor referred them to. How can they really trust you? How can they know that they are in control when they really don't have control? Sometimes your difficult patient is just struggling with the issue of control. It's okay to acknowledge how hard that can be. Be understanding of your patient's loss of control and how that might be playing out in your clinic. We're all educated to inform our cancer patients about acute and late toxicities, yet we rarely describe what happens during therapy. When I arrived for my first adriamycin and Cytoxan cycle, I wasn't prepared for the drama of the nurse sitting down in front of me with a 60 cc syringe of this hot pink fluid that she was ready to do a slow push into my IV. I was petrified of what was going to happen when that fluid started flowing through my veins. I needed someone to tell me you're going to feel nothing. I now tell every patient you're not going to feel anything when the radiation beam is on, and you're going to walk out of the treatment room as if nothing happened. I expect my residents to do the same, and even if your patient doesn't say this, when they're lying on that treatment table before the very first fraction, they're nervous and anxious, and they need you to tell them. It's difficult to appreciate the nuances of an experience until you have lived it yourself. While I consider myself a relatively compassionate, insightful people person, I was surprised by many things I didn't appreciate until I went through them myself. My doctoring really hasn't dramatically changed, subtle shifts, and I hear things a little bit differently. A simple example relates to seeing my follow-up patients. I would routinely ask them about toxicities of therapy. Are they having any hot flashes? I spent a lot of time managing hot flashes and was very comfortable with the rubric of management. But what did I know? I was a 41-year-old premenopausal female. I didn't take this problem too seriously. So after my first cycle of chemotherapy, I began to have these intense episodes of sweating, and I felt like someone had lit a heat lamp inside my head. These were extraordinarily uncomfortable, and I had to leave several meetings and social events for the cool breeze outside the room. And it's funny, in retrospect, I really had no idea what was happening. And one day in my kitchen, it occurred to me, oh, that was a hot flash. It suddenly struck. And now I think of hot flashes on a much more serious level when I deal with my patients in clinic. After I finished a lumpectomy, sentinel lymph node biopsy, dosed NSACT and whole breast radiation therapy, life was supposed to go back to normal. But I began to have trouble sleeping. I was plagued with the question, did all this really work? Your patients have the same question. They don't know, and you don't know. There is comfort for some of us in the difficult, time-consuming treatments, and it can be frightening to stop. I was reminded that ovarian suppression and oral tamoxifen were very powerful yet easy treatments, and that was helpful. So now I inform my patients on the last week check visit to be prepared that it's possible they may notice an increase in anxiety. And if it lasts for more than 6 weeks, they should call me and I can offer them some additional help. While it sounds cliche, we should all bring more than just evidence-based medicine into clinic. Bring your best qualities to your doctoring. Every patient wants to feel that they know you and that you understand who they are and that you have their back. And no, there are no RVUs associated with that type of work. At my routine annual mammogram 5 years after diagnosis, the tech called me back for additional views, which I was used to. They were always fascinated with the lumpectomy bed. And as I pivoted my body to that side, the tech said, "No, your other side." I was confused. During the ultrasound that followed, I could easily appreciate the hypoechoic anti-parallel mass with posterior shadowing, and I knew what I was looking at. Laura, my colleague and breast radiologist, also knew that I knew. She paused and said, "Do you want me to get Ginger into the room?" She's my medical oncologist who had just finished examining me just an hour before. Doing this slowed down both Laura and Ginger's day, but Ginger came in and held my hand during that breast biopsy. Their combined compassion and kindness were immeasurable to me. Be a little bit like Laura and Ginger. After receiving a cancer diagnosis, there are a host of conversations that we have to deal with, a whole variety of decisions that no one prepares you for. I knew what that biopsy would show. I cried in the car the entire way home. I didn't want to worry my husband about the inevitable diagnosis until I had that pathology report in hand. That evening, he asked me why my eyes are red. He's an allergist. I told him it was hay fever. It was December in Colorado. Somehow that answer worked. I was in anguish thinking of how to tell my kids who finally felt safe that we were about to go through this all over again. I anticipated seeing the worry in my friends' faces, which was an added burden. I didn't want to tell my overly dramatic mother about this diagnosis and deal with her response. Perhaps you think I shouldn't have been worrying about all these people, but I suspect many of your patients do. I am blessed with a husband who has always been by my side and a wonderful community, work environment, and economic stability. But many of your patients don't have the benefit of those resources. Know that your patients have a lot to manage outside of their direct cancer care. I handled my first diagnosis pretty well emotionally, but after my second diagnosis, the bottom fell out. An MRI demonstrated multicentric disease on the contralateral side. How could I have developed breast cancer again only 4 years after dose-dense ACT, ovarian suppression, while on adjuvant tamoxifen? At the age of 46, I was just beginning to feel my legs again. My recurring thought was, what is left to do? I felt doomed and out of options. I had days of complete and utter panic. I couldn't focus or concentrate. I prayed that God should just help me live long enough to see my kids through high school. My therapist, Stacy, who I adore and declined to be photographed for this slide, was an absolute lifesaver for me. You don't need to have cancer to benefit from a therapist, but cancer is a great reason to see one. Be sure to remind your patients of mental health resources at the start of their cancer journey and at every follow-up visit. Ensure that your patients are doing well during survivorship, both medically and emotionally. At this point, staging studies were ordered for the first time: CT scan, chest, abdomen, and pelvis, and bone scan. The nuclear medicine tech, who didn't know me, went through his usual spiel. We'll take standard pictures, and if the doctor has any concerns, she'll take a few additional images. He returned 10 minutes later and said, "The doctor wants to take additional views of your lumbar spine. Please go into the bathroom, empty your bladder," and came back. I went into the bathroom and started sobbing. I knew I had metastases in my lumbar spine. In the end, the radiologist came out and explained to me that because of my lumbar lordosis, it had affected the image quality in my lumbar spine, and so she had to take additional views. But I didn't know that, and no one had explained that to me. Patients make intelligent but incorrect decisions based on what you say and what you don't say. So try to be as clear as you can and anticipate their interpretations. We doctors are very MD-centric. We forget that the patient experience may be more impacted by others on your team than you. Nurses, therapists, medical assistants, front desk staff, people they interact with more than you. After my bilateral mastectomy and DIEP flap, my surgeon visited me for less than 2 minutes on most days. I was moved by Marta, who helped me bathe when I had 3 drains and full, swollen wooden legs that didn't seem to work. Candy, my day shift nurse and biggest cheerleader, came into my room at 7:30 a.m. on post-op day 2 and excitedly announced, "Rachel, today you're going to take a walk down the hall and have a bowel movement." My day's accomplishments were reduced to the most banal activities, but she made them seem as dignified and important as submitting an abstract to this meeting. To this day, I have a list of names of the nurses and MAs who cared for me during that hospital stay when I was the most physically vulnerable. They cared for me with warmth, compassion, and respect. The unexpected happens all the time in medicine, and yet we always seem to be surprised. 1 month after undergoing the mastectomy and DIEP flap, I developed an itchy cough and lost my voice. When it didn't recover after 10 days, I was diagnosed with bilateral vocal cord granulomas. It turns out that 10 hours of irritation of an ET tube on the vocal cords can cause this. I couldn't speak for 4 months, even while in clinic. No one had mentioned this side effect to me, and I don't blame the anesthesiologist. I don't think it's too common. But it did lead me to consider, why don't anesthesiologists see patients in consult before surgery? And why don't they see follow-ups? And how do we handle unusual, unexpected toxicities? Similarly, patients know when they have an unusual presentation. My second cancer had an oncotype of 32 actually, indicating the need for chemotherapy. Yet it had developed within 4 years of dose-dense ACT, the most aggressive regimen for my type of breast cancer. I was appreciative of my medical oncologist Ginger's explanation that this was an unusual scenario and that she would consult with several colleagues of hers across the country. I was incredibly relieved when they all unanimously returned with a recommendation for adjuvant CMF. We shouldn't be afraid to tell our patients that their disease exists in a data-free zone and that we will consult with others for a consensus, especially those of us with big egos or reputations. In oncology, overall survival is still the gold standard endpoint. At an NCCN lymphoma conference, I presented the data from a trial demonstrating a double-digit disease-free survival benefit from adjuvant therapy at 10 years following definitive radiation therapy for early-stage follicular lymphoma. A nationally recognized medical oncologist at the table said, "I'd much rather give chemotherapy when the patient relapses since there's no survival benefit." The other medical oncologists started to nod their head in unison. I was stunned. Did none of them consider that people don't want to live with cancer? Would they prefer to live with cancer even if the overall survival benefit isn't any different? I view study outcomes differently now than I used to. Patients may not give you a physical gift, but when they thank you with words, that is their gift to you. I used to respond to expressions of thanks with a glib, airy, "Oh, it's nothing, that's my job." But I think that trivializes the depth of what they are trying to express to you. I now say thank you. Your words are very meaningful to me. And a last thought. When speaking to fellow oncologists with cancer, many of us have a unique experience given our background and training. It was difficult for me to find people that I felt understood what I was going through. I felt alone. My patients didn't have the information and experiences that I had. I saw patients who relapsed with incurable cancer all the time, and my colleagues didn't really understand what I was going through. I suspect there is a need for a resource, one that does not yet exist, to serve the oncologist cancer patient. So if any of you in the audience or anyone you know are an oncologist who have or have been treated for cancer and find this interesting, please reach out to me and let me know. I'm thrilled to tell you that I celebrated my 58th birthday last week and remained cancer-free. On behalf of the cancer patient community, I want to thank each of you for your compassionate, attentive care that you give us each and every day, and may we all rise to be the best caregivers that we can be. Thank you. Thank you.